I'm going to ask Sharon to introduce herself. Sharon spices this conversation because she's from Kenya, and we are going to hear what happens on the other side of the border.
Yes.
Thank you very much.
Thank you as well. Good afternoon, everyone. Good afternoon. Yes, as she's introduced me, my name is Sharon Mokua. I come from Kenya. I'm from the Kenya Medical Research Institute. As she said, I'm going to spice things up, and I'm also going to take you a bit away from the statistical perspective that my colleagues or my fellow presenters have given you. I'm going to give you more of a qualitative feel to what we have in Kenya with regards to UHC. So my topic is on making health everybody's business, ways of addressing key health determinants as a responsive approach for the implementation of UHC. So this stems from what we have in Kenya, in that we're just rolling out universal health coverage program for the population in Kenya. And these are some of the lessons we learned from the implementation, from the start of when it was rolled out, and how we're going to move forward as Kenya, as East Africa, as a country, as a continent, and also globally. So I'm just going to give you an introduction, justification, objectives, methodology, key findings, conclusion, and recommendations. So from what we know, I think it's already a song in our heads, what UHC is. It means that everyone, each and every single person and communities receive health services they need without suffering any financial hardship. And currently, UHC is embodied in the Kenyan government's Big Four agenda. So we have something that our president rolled out, and that is focused on 4 key areas as we move forward. That is in agriculture, housing, manufacturing, and in healthcare. So UHC is cemented in healthcare as one of the agendas in the in Kenya presently. And the global commitment to UHC strongly lies in renewal of primary healthcare. This is what a lot of emphasis is on, especially in Kenya. We have to go back to the basics of primary healthcare. And one of the 3 crucial interrelated synergistic components of primary healthcare is systematically addressing social health determinants. This has been said time and time again. I'm sure it's become a norm until we at some point forgot that issues such as employment, housing, education, family income all contribute to a person's health outcome, because overall what we are focused on is the health outcome, not the processes that are as important as being healthy, having the quality of life for an individual or for communities. So for instance, I've given the examples of the health determinants: employment, housing, education, some fall under politics, water, sanitation, and hygiene, among many that we know. And why address social determinants of health? At presently, what we have in Kenya, we are focused on expanding coverage. That is ensuring everyone is able to access health services at point of entry into a health facility. But this is not necessarily sufficient to address the whole healthcare aspect of an individual or for community, for us to realize health for all. Determinants also affect access and coverage of essential interventions, and they also directly affect health, including shaping social norms and behavior. So social determinants of health are really at the base. They're the core of what we term as wanting everyone to be healthy at whichever time point. And you can see I've just given you a diagram to show how primary healthcare is interlinked to universal health coverage, and how it's also linked to the Sustainable Development Goals. And from evidence, countries and states that have made most progress in improving social and economic determinants of health have also demonstrated the best health outcomes over time. So the justification for this particular study was to increase recognition on social determinants of health. Time and time again, the health determinants have been a paradox. They've been recognized all over the world, but there's been limited action. There's been fragmented action from different sectors, as I may say. And also actions to address underlying determinants are just as important as the healthcare services itself. And the contribution or lack thereof of multi-sectoral interventions to the health-specific goals has been insufficiently tracked and documented. By this, I mean probably they have been contributing, we've not been documenting, or probably they have actually not been contributing to addressing the social determinants of health and overall improving the health outcomes of individuals. So the objective of the overall study of what we did in Kenya at the onset, UHC was rolled out in December, but it began with piloting in 4 different counties in Kenya. And what the study was to do was to explore the population-driven needs for an effective UHC program. So it's a pilot. So they're rolling out a program to see, we are giving out this particular package or this particular services to the population. Let's see how it goes. Let's pilot it for a couple of months and see what we need to work on, where we need to make amends, or should we move forward with what we have. So this particular paper sought to explore the various key determinants. As of when we did the study, it was between January and February. We wanted to know the state of affairs. Where is it as we start? We've said we're rolling out UHC. So where are we as a country? Where are we as counties in Kenya? It was an exploratory qualitative design under which we used focus group discussions and in-depth interviews to elicit responses from the population. The target population was majorly the general population, which included women of reproductive age, youth, the elderly. We included each and every single person, and our key informants were health service providers and the county health management teams. Of course, ethical considerations were seen through, and the data management and analysis of our data goes through the usual process of transcription, translation, and then we get themes out of our data. So I'm just going to go to the findings. Of course, when you carry out a study, you do have the pros or the good, the bad, and the ugly. I will start with the good. From what we found on the ground, at the implementation stage, there was availability of community-based resources and support of community living. In that, as we rolled out the UHC, we found that community health volunteers were key. They were used in the sensitization and registration process in onboarding their fellow community members within their communities. So that was a plus for us. So that just because it was a plus, it doesn't mean we can capitalize on them for future. Probably go to community level and give out more primary health care services. And it showed that in some communities, community structures are in place. It may not have been in all communities, but in some communities, community health volunteers were strong key persona in the implementation phase. Another upside, there was access to mass media and emerging technology. Sometimes we take this for granted as nations because we have some people who may never access mass media and they may never know what is going on. But presently in Kenya, we do realize that there were radios in which the message was relayed about UHC. It brought a bit of understanding to the community members. There may have been a bit of misconception. That means we need to capitalize on what we have. We already have technology. We already have mass media. So how do we capitalize on ensuring that we maximize on relaying the same information, the correct information to community members? How do you also ensure that mass media plays a crucial role in overall health outcomes of populations? So I put extracts here just to give you a feel of what our respondents said. Some had it from the radio, some had it from those who are going to register them, those are the community health volunteers. Some had it from the mass media or through the community CHPs, as I said. Some even have television. Some are privileged, some are not. And that could give you a feel of what was happening in the different counties. So I'm going to go straight to the downside. Those are only 2 upsides of what we found on the ground at the implementation stage. The downside is that there's still poverty. Poverty is something that is rife, something that is still being worked on, and it's a condition that contributes to health inequalities. If we do not work on poverty on the onset, then probably our efforts in trying to offer free services or trying to have health services at health facilities they'll probably dilute each other. They'll cancel each other out for every and any health service. So that's what the public health facilities are currently doing. They're offering any health service to anyone who walks in and is registered with a UHC card. So what they say is that the services are free, but still issues of poverty come in. Some may not have money to pay for transport to come from their house to the health facility, even if the services at the facility is free. So that means there's still a gap. There's a way we need to reach the community members, not just by offering health services at the health facilities free of charge, but how do we reach them? How do we get them to come, or how do we go to them to ensure that they also do not continue to suffer out-of-pocket expenditure, either directly or indirectly? Evidence is also that, as much as UHC is free, we get patients who come to the CCC and living with HIV, they already have free medication. So UHC is free. But people still do not go to the health facilities, or you still find defaulters. What is the problem? Where is the issue? Medicines are free, health services have been free for the people suffering from HIV, but still you come to find that they're defaulters, people do not keep up with the health system. So that's a gap. And also where there's poverty. So a second respondent noted that there's poverty and also a lack of education. So this may consequentially affect the behavior of, let's say, community members, such as someone noted was a pregnant. Young school children still find themselves pregnant because they're deceived, and someone can give them money and they get pregnant consequentially. So this is an issue of poverty. If someone is poor and they need money to, let's say, access services, or they need money for A, B, C, D, E, they resort to probably engaging in other activities that would consequentially affect their health overall. Also, we found that education and health literacy at community levels, for some communities, they do have low literacy levels, and it's associated with poor health outcomes. In the villages, one respondent said, some respondents, also community health volunteers, say, first and foremost, if people are not educated, and if they lack education, they may not understand the health issues. You may give them health services for free, but they'll keep coming back because, you know what, they do not know how to take care of their living area. They keep on coming with malaria because they do not know how to probably use bed nets. Probably they do not know how to make their the environment safe and clean. So they'll still keep coming back to the healthcare services. We keep providing for them. They go back and still keep coming back. And also the problem they face in the villages is that people do not know the benefit of good health. That is one of the issues surrounding education and health literacy. We also have another issue of culture and norms. We all know that culture and our norms, they do influence how we behave, our health behaviors, how we access health, what we want, how our perceptions on health, illnesses and deaths and diseases. In this culture and norms, what we noted is that from one of the communities is that women still give birth at home, even when health services are free. We know that one of the programs that was rolled out in Kenya was Linda Mama, where pregnant women can access health services for free. They can give birth at health facilities free of charge. But still, they deliver at home. What's the issue? It's an issue of culture. Apart from culture, there's also the norm. Some communities are nomads, so that means they move from place to place. Setting up a health facility at point A may not necessarily be of benefit to them because they keep moving around. So how do we find ways to reach such communities who are nomads or who go from place to place with regards to seasonality? We also found an issue of poor water, sanitation, and hygiene practice. This is a bit common. It was a bit common everywhere. In that, some community members mentioned that where there is drought, then there is water we drink that is not clean. Therefore, diseases like typhoid and amoeba are common. So that is also an issue. That's a gap. We may offer health services, but if the people's surroundings are not free of, if they're not safe, if they don't have safe water, if they don't have, if their sanitation and hygiene practices are poor, then that means they'll keep on coming to the health system, and there's that whole cycle, and we want to break the cycle. Also, poor road networks and geographical accessibility. At that time point, some people lived in areas with minimal geographical access to, let's say, to the health facility, to towns, to cities. So that is sort of an impediment to them accessing health services, for instance. And if we have poor road networks, that means there are no access roads, and if there are no access roads, that's a problem. Even for the elderly person who lives in a village in place A, B, C, D, E, that means they'll not be able to access health facilities and get themselves the health service they need. As a discussion to this point, what I noted is that no institution or individual can deliver public health alone. It has been said time and time again from the beginning of this symposium that we need multi-sectoral approach, and not only multi-sectoral approach, we need everyone. We need to make health everyone's business. Your business, my business, the health system's business, and each and every sector's business. So how do we prioritize social determinants of health for individual patients and communities? That is a question to you. How do we intervene without necessarily medicalizing social determinants of health? We may be focused on, on putting up health facilities, giving medicines, dispensing medicines, but for how long can we sustain our community's health by continuing to dispense medicines, even in cases where we know there are more underlying issues towards solving the problem other than medicalization? and what new data is needed. For researchers, what new data is needed to feed into what we need to know about social determinants of health? What else do we need to know? What new data can we find out there? And how do we build multi-sector partnerships? We need innovative ways to do this. And then what else? Does anything else come to mind when it comes to social determinants of health? So the goal of UHC itself is dependent on the individual, the health sector, as well as multi-sectoral collaboration, just to give you an overview. And for the individual community, empowering them to take charge of their own lives is the first place to start. If an individual is not empowered to take care of their own health, then that means they may not be able to have their health on their own hands. So therefore, we should aim to develop interventions, whether individual or at policy level, that influence lifestyle, as one of them, towards healthy living. For the health sector, we can develop frameworks to integrate social determinants of health into primary health care. Most of the times we see this as separate entities, but in what way can we integrate social determinants of health into primary care such that we monitor these determinants and know if mama so-and-so lives in this village, why does she keep coming back? Is it her environment? Is it where she lives? Because she keeps on using firewood or charcoal, you see? So she comes back every time with asthma. Her daughter comes back every time with asthma and pneumonia. You'll treat that as a doctor at the health facility. But if we have data on the social determinants of where a person lives, of what they do, where they work, then we'll be able to track that and know exactly where the root of the problem is. If we go to the various non-health sectors, let's say the industry, the road and public health, what roles do they play in addressing the social determinants of health? The road and public works, their work is to create roads, to create accessibility for each and every individual. The work of the agricultural sector is to, create food security for each and every one of us. And if they also don't have regulations in that, food is there in plenty, but where has it been grown? Is there regulation to whoever uses the wrong fertilizer or fertilizers that harms our health? There needs to be that wholesome monitoring and regulation for each and every industry that is not within the health sector, such that we foster accountability and we can document what role they play in each and every person's lives or in the different communities. So in conclusion, I think UHC presents opportunities. It has opened doors. If UHC was not here, there'd not be a buzz around it. And once UHC is here, it's opened up doors for us to start focusing now on what is affecting the community, the social determinants of health, for instance. And they're greatly influenced by policy, systems, and environment. So there's potential for multi-sectoral collaboration, but it still remains untapped, still fragmented. And it's key to ensure that the UHC agenda addresses the capacity of the health sector to work with other sectors. Since UHC has become a buzz, let's capitalize on that buzz. How can UHC, the health sector, how can UHC foster the health sector to work with the other sectors? Since each sector has a different contribution to solving specific health problems. And in each case, the profile, interests, incentives, and relationships of key individuals and sectors must be mapped and analyzed to inform the design of different approaches. The designs which everyone is talking about, we need to be innovative about this, we need to be innovative about that. And for our take home, action number one should come from the individual, the community. Empower the communities to optimize their own health. At the health systems level, recognize and address health-related social needs to build the healthcare system. Then at multi-sectoral level, focus on health in non-sectors and link these sectors to the health sector, such that, because our overall goal is to ensure that everyone is healthy, health for all. And there's also great potential for developing, this is one thing Professor Rogo mentioned yesterday, you should develop a win-win or strategic win-win-win. Mine is missing a one win, but it's the same thing, or strategic innovative interventions focused on developing effective multi-sectoral engagement. And all this may be futile if we do not have the willing political and governance structures to foster the agenda of UHC and addressing the social determinants of health issue in the nation. So I'd like to acknowledge all the below, the Ministry of Health, the Kenya Medical Research Institute, for supporting us in this study, the stakeholders, the health facilities, and the participants as well. And that would be my presentation.